Dr. Ritesh Roy is an Associate Clinical Director and HOD at Care Hospitals in Bhubaneswar in Odisha. He is the innovator of many different blocks and an executive committee member of AORA India and has received the Lifetime Achievement Award in 2019. His special interests include USG-guided RA and difficult airway management.
Good afternoon, everyone. Today, right now, I will be speaking on IPACK. So what is IPACK? It's the infiltration between the popliteal artery and the capsule of the knee, that is IPACK. And it was first described by Dr. Sanjay Sinha. So he is a pioneer, he is there in the conference. So if I clear your doubts, well and good. If any doubt is left, you can personally interact with him and clear your doubts. So what is the goal of IPACK? It's a selective blockade of the innervation of the posterior knee joint, sparing the main trunks of the tibial and common peroneal nerves and maintaining the sensory motor function of leg and foot. And what is the target? Target is the popliteal plexus, which is formed by the articular branch of the tibial nerve, articular branch of the posterior obturator nerve, and the posterior branch of common peroneal nerve when present. It's not present in 100% of the patients. This popliteal plexus, it travels through a tissue space between the popliteal artery and the femur, and it innervates the intra-articular genicular structures and the posterior capsule of the knee. And it was first described, the first IPACK which was described, that is a distal IPACK by Sanjay Sinha in 2012 at ASA, American Society of Regional Anesthesia meeting. And coming to the original technique, that is a distal IPACK, that is at the level of the femoral condyle. This is the anatomical concentration. Once you put your probe, you have the two knee condyles. Then these are the femur condyles. Then you have the popliteal artery. This is the sciatic nerve. Your needle will come between the popliteal artery and the condyle, and the drug is deposited. So the original technique, the patient position which was described by Sanjay Sinha was a prone position. But ergonomically, while giving a block in a prone position, then again making it supine, it becomes slightly complex. So we have modified this technique of patient position. It's a supine frog leg position with leg elevated on a bolster, and we use a curvilinear probe or a low frequency probe. So what is the scanning sequence? First, you put your probe on the popliteal fossa. As you put your probe, you see two condyles, and you see the popliteal artery and the tibial nerve. From there, slide your, and put a color Doppler to see the pulsation of the popliteal artery and confirm it. From there, slide your probe up. As you slide your probe up, the one femur condyle will become flattened up. That is, you come at the shaft level and you see the lateral condyle, the shaft and the lateral condyle. And again, put a color Doppler to confirm the popliteal artery. Your needle will come in plane from medial to lateral, and you deposit the drug between the popliteal artery and the femur. Okay? So this is the way needling and LA deposition is done. This is a popliteal artery, this is a tibial nerve, this is a common peroneal nerve, this is a femur, this is the lateral condyle of femur. My needle tip will come between the femur and the, I will cross almost 2 centimeters beyond the popliteal artery. That I will tell why I cross. And with frequent aspiration, I will deposit 3 ml, withdraw my needle, again deposit 3 ml, and this is the way you flood the space between the femur and the popliteal artery, and the drug deposition starts. Now a new approach has come up to make it more ergonomically more easy. That's a posterior medial acoustic window approach, or the proximal IPACK, that is above the patella level. And you see the vastus medialis muscle. This is a femur. This is a popliteal artery. This is a sciatic nerve here. Your needle comes from anterior to posterior in supine position, and the drug is deposited between the femur and the popliteal artery. This is the way the scanning sequence, the patient position is same in a frog leg position, supine, curvilinear probe we use, and this is the scanning sequence. The probe is put on the medial aspect of the thigh. You see the femur, you see the sartorius muscle, you see the vastus medialis muscle, you see the adductor magnus, and this is the superficial femoral artery. From there, slide your probe down. As you slide your probe down, the superficial femoral artery becomes the popliteal vessel. From there, put the color Doppler to confirm the popliteal vessels. From there, slide your probe infromedially. As you slide your probe infromedially, you see the femur, you see the femoral condyle. This is the popliteal artery. Your needle will come in plane from anterior to posterior, and the drug is deposited between the femur and the popliteal vessels. Okay? So this is the scanning sequence of the posterior-medial acoustic window proximal IPACK approach. This is the way the needle will come from anterior-medial aspect to the posterior-medial aspect. The needle will cross, the needle tip will cross the popliteal vessels. You have to remain towards the femur. Don't put your needle towards the artery. You have to remain towards the femur. After you cross the popliteal artery, your needle tip crosses the popliteal artery, deposit around 5 ml here. Start withdrawing your needle while the assistant is injecting. And this is the way you flood the space and you block the popliteal plexus. So what is the LA volume and concentration we use? Right now, we use 15 to 20 ml of 0.2% ropivacaine or 0.2% bupivacaine or levobupivacaine. And what is the indication of IPACK block? Post-operative analgesia following TKR, ACL repairs. They work wonderful in ACL repairs and any procedures involving the posterior aspect of the knee. So coming to the innervation of knee joint, which is relevant for TKR. In TKR, you have got two groups of nerves, the extra-articular group of nerve and the intra-articular. The extra-articular group of nerves you can take care by giving adductor canal block. But for the intra-articular, it is by the popliteal plexus, and here your IPACK will work. So the combination of adductor canal block plus IPACK will give you a complete analgesia following a total knee replacement. And these are the studies which have compared adductor canal with IPACK. They found that VAS score was better in adductor canal plus IPACK group compared to adductor canal block alone, and range of knee and ambulation were better in the ACB plus IPACK group. This is another article which has compared the implementation of IPACK block into a multi-modal analgesia pathway for the total knee replacement. What they found with IPACK, the pain score was less on post-operative day 1. Same analgesic efficacy of adding the IPACK block to multi-modal analgesia for a primary total knee arthroplasty. The IPACK block reduced the incidence of posterior knee pain 6 hours post-operatively. There is another article which has compared the IPACK with a periarticular multimodal drug injection. They found the IPACK was better compared to the periarticular drug injection. Same, they found IPACK combined with femoral block is an excellent analgesia strategy for total knee replacement, achieving adequate pain control, prompt rehab, and early ambulation. What is the role of IPACK in ACL repairs? This is an article which compared the LIA group with IPACK group. In IPACK group, they received 42% of the patient received less morphine than LIA group, but there was no significant difference in the pain score, but overall opioid consumption was less. In this, they have used a series of cases for adolescent ACL repairs. They found IPACK gave a better post-operative pain control. The addition of IPACK and adductor canal block significantly improves analgesia and reduces opioid consumption after ACL repair compared to periarticular infiltration. So you can combine IPACK along with adductor canal block as a multimodal analgesia for ACL repairs. But in my practice, I give only IPACK following ACL repairs. I don't combine with adductor canal block because it's mainly intra-articular structures which you are dealing in ACL repairs. So IPACK is enough to take care of that. Does IPACK block the articular branches supplying the posterior knee capsule? in an evaluation of IPACK block injected in a cadaveric study, they compared both the proximal IPACK and a distal IPACK. What they found, the staining of the posterior knee capsule, that is the genicular branches, was much better in a distal IPACK group. And the enterolateral knee capsules knee capsule genicular branches were better stained in a distal IPACK, and the enteromedial capsules, which is supplying the enteromedial capsule genicular branches, are better stained in a proximal IPACK. This is another article, a cadaveric study. They found where they used only distal IPACK, there was a consistent surrounding of the middle genicular artery with injectate, suggests a potential mechanism of analgesia for IPACK due to a predictable relationship between articular sensory nerves and the artery. Does the addition of IPACK benefit patient undergoing total knee replacement compared to the current enhanced recovery pathway? Yes, the first 24 hours opioid consumption was less in 2 studies. In 2 studies, they didn't favor IPACK, but they didn't disagree on it. And 4 studies, they found there was no significant association in the first 24 hours in the opioid consumption. Does the assessment of post-operative pain with movement in first 24 hours is affected by IPACK? 3 studies were in favor of adding IPACK. 2 studies were neutral, and 2 studies found no difference by addition of IPACK in their multimodal analgesia. Which IPACK technique is preferable? Patients who received distal IPACK reported improved preservation of motor function compared to those receiving proximal IPACK and tibial block. The posterior knee pain score were similar in distal IPACK and tibial nerve group, but were significantly worse in a proximal IPACK group. And these are the results which they found. So what is the optimal location of local anesthetic injection when you are giving a distal IPACK? This was reported in a Korean journal. What they found, that the level below the upper edge of lateral femoral condyle in the area of tibial nerve immediately superficial to the popliteal vessel could be the optimal level to perform an ultrasound-guided distal IPACK block. Why? At this level, the articular branch of tibial nerve emerges lateral to the popliteal artery and forms the popliteal plexus. What are the relative contraindication of IPACK? Baker's cyst, if you have aneurysm or pseudoaneurysm of the popliteal artery, or there are masses that discharge the tissue plane between the popliteal vessels and the femur. What are the clinical pearls of a IPACK? Distal IPACK is the preferred technique, which has been shown by the different studies. Needle direction should be from medial to lateral. Why? To prevent injury to the common peroneal nerve. If you are coming from lateral side, there are chances that you will injure the common peroneal nerve in the way. To prevent tibial and common peroneal nerve block, because you don't want the tibial and common peroneal nerve to be blocked. What you should do? The needle tip should not be more than 2 centimeters beyond the lateral edge of popliteal artery. First point. Inject in 3 ml increment and slightly withdraw the needle with each injection. Needle bevel should be oriented anteriorly, not posteriorly, because if your bevel is posterior, the drug will go posterior and will block the tibial and the common peroneal nerve. Decrease injection pressure, because more injection pressure, more spread. Decrease LA volume. We have started using around 10 ml in popliteal blocks, in IPACK block. We are getting results. We are collecting data. We might come with a publication, and it's a thing which you can also research in your institute by decreasing the volume to 10 ml. Thank you very much.